And here he is, Joe walks out.
All right. First off, he said, say something interesting about yourself, and I couldn't think of anything interesting. And I said, well, if I had my druthers, I'd actually rather be racing sled dogs in Alaska, which Justine knows because we both were pretty obsessed with it back in vet school. And then I said, and if that didn't work out, I'd like to play tambourine for Prince and be on tour. And he said, now that's interesting. So anyway, we're going to talk a little bit today about obesity, and we're going to really go through this whole idea of fat as an endocrine organ. And I first want to say that I probably shouldn't be here, but strangely enough, I was doing a little hyperthyroid study with Hills, looking at their YD product for cats, but I'm not talking about cats today. And then I had a little bit of money at the end, and they said, well, what do you want to do with that? I said, I have Labrador samples in my freezer, and I would love to look at all these Labradors and see, based on body condition score, what the overall inflammatory status is. And they were like, go for it, have a good time, because this is a really interesting topic. Do dogs have chronic inflammation of obesity? Are they any different from humans, etc.? And of course, we've been looking at obesity a little bit, because it is probably one of the hottest topics around these days, is how do we keep our pets lean? And this is one of our study dogs from when we were doing a weight loss study. This is Gus McNamara. And Gus doesn't look quite as fat on these screens as he did on my screen on my computer, but he did look like a tick, and that's why I always like to show it, because he was kind of round in the back. And his owner, I think, was a physicist, because I think she knew that matter and mass in the universe does not change at all. And she would bring in plates of brownies for every visit. And we would eat the brownies, and Gus would lose, you know, a half a pound, and then we realized that we were gaining the weight that Gus was taking off. So, yeah, I give it to Joan for being a physics major. But what I'd like to talk about, and I think I'm realizing this microphone is scratching on my beard, so I'm going to try and move it a little bit. You can't hear me now. I am not Janet Jackson. That's the problem. So, can you hear me now? Yeah? Okay, good. Hopefully it won't scratch on my face as much. Obviously, I have a much bigger head than Dr. Marson Little. So as we move on here, we're going to talk a little bit about a variety of things today. So we're going to talk a bit about the pathophysiology of obesity. We're going to talk about eating behaviors, because we're realizing that there are a lot of hormones out there that probably influence eating. Now, what I will say is that we're talking about eating behavior. This is probably not the best place to talk about it, because every time you walk outside, there is a whole table full of great things for you to eat. So you're all going to gain 2 to 3 pounds while you're in Miami. So go running with Dr. Marson Little tomorrow morning to try and negate that. We're going to talk about adipose tissue. And the adipose tissue is an endocrine organ, of course, releases things that are called adipokines. We're going to talk about dogs and how they may be a little bit different, and we're going to realize that dogs are special, as we all probably deduce anyway. We'll talk a little bit about chronic inflammation of obesity, the cytokine milieu that may be released from fat tissue, and I'm going to introduce you to some of this Labrador data that we've pulled together. So obesity is not quite as simple as we were probably taught, which is calories in, calories out, right? The number of calories you take in is all part of the physiologic response. We all have a basal metabolic rate. So Speakman, of course, decided to make it much more complex, and he puts together this wonderful little algorithm here, or this flow chart, basically telling us that, yes, we have genetics, and we have physiology, and we have our basal metabolic or our resting metabolic rate. We have our active metabolic rate. If you go running, you're going to be able to eat an extra Gatorade energy bar out there today. And all this relates to our energy expenditure in general. Now, the energy intake is the big part that I think we all have a problem with from a behavioral perspective. Because if you actually walked in here this morning and didn't see food and all these goodies out on this table, you'd be like, Hills, they're kind of cheap. You know, they're not very nice to us. I mean, come on, where's the Danish? Where's the little power bars? Where's everything? And the bottom line is that I think we're in this behavior of consumption. Anywhere you go, there's always going to be a little bit of food around. Is your brain driving that food consumption? Probably not. It's there. It's just exposure. It's being accessible. So your micronutrient or macronutrient intake is really dependent on behavior. Is your friend eating a Danish? Well, what the heck, I'm going to have one too. And it's exactly what your Labrador does when you go out on a walk. Is you come in the house, and he goes and he sits there and he by his treat jar, and he looks at you like, it's treat time. And so you, of course, have a treat, probably too. You grab an extra piece of toast, and you give him something to completely negate that walk that you just went on. So if we talk about eating behavior, the reality is these are all the various hormones that are released either in the central nervous system or the periphery that actually influence eating behavior. You probably can't see a lot of this, but we'll go through some of this sort of in a play-by-play type of a scenario where we look at some of these hormones. But what we tend to have are orexigenic or anorexigenic signals. And you can see here, I'm putting a red arrow on the orexigenic signals, okay? So those are things that make you eat or make you want to eat. Then we have anorexigenic signals. Those are things that make us say, really don't need to eat right this minute. And you can see there's a whole variety of things on here. Neuropeptide Y is orexigenic, agouti-related peptides orexigenic. Anorexigenic agents are things like melanocortins, cocaine, amphetamine-related transcripts that come from the central nervous system. We'll talk about exactly where. We can see that we have cool recreational type things like endocannabinoids. Okay, so the endocannabinoids stimulate an appetite. Not that we have any recreational users here, but that's why you get the munchies, right? Legal in Colorado, absolutely, so it's not legal everywhere. And then we have things like the cocaine, amphetamine-related transcripts, which are anorexogens. So not that we have any recreational users in here that use those types of things, but when you're a little hopped up, you don't really want to eat, okay? So we can see how we've sort of discovered a lot of these things. Now, all these things that we're really talking about come from the central nervous system. They're somewhere in the hypothalamus. They're sort of being released on a regular basis to sort of dampen or enhance your appetite. Then we also have some pretty cool peripheral cues here, okay? So we have things that come from the periphery. Now, these are the cool ones because these are the probable pharmacologic targets. If you look at the peripheral ones here, we actually have just one that comes from peripheral tissue called ghrelin, which is an orexogen. It says, hey, let's go have something to eat. Let's go to McDonald's. And then we have over here a whole bunch of things that are anorexogens, insulin being probably the most popular one. We have things like peptide YY, GLP-1. So there's a whole bunch of things that are being released that are really dictating when and where and how you eat. So we'll go into the idea that there is a signal that has to be related to all these hormones being released. And I'd say 15 years ago, Speakman kind of did this nice little article talking a little bit about protein versus lipid versus carbohydrate, and who is the real winner in terms of who is signaling for us to release various hormones to turn on or turn off the appetite. What I'll tell you is that the lipostatic model wins, okay? Hence, your fat tissue releases things that may actually influence your appetite. And also, the fat that you take in is probably one of the better stimuli for turning on or turning off the appetite. So we'll talk a little bit about how that happens and why that happens when we start talking about some of these hormones. So our first fun fact of the day is what hormone that is released from fat tissue will influence your overall feeding or eating behaviors. Lameness. Just kidding. All right. Nobody likes peptide YY, huh? So we got 65, 70. Oh my God, here it goes. Hitting towards 100. We had 20 people leave to go to the pool. I can understand that, that's for sure. So we got up to 95. And we see that a lot of people are sort of going between adiponectin and leptin. And so the leptin people win, okay? So the reality is that leptin is what is released from the fat tissue that truly influences your eating behavior. Adiponectin is also released from fat tissue, so you're not wrong. It's just that it's not really directly related to your eating behaviors. So let's make this even more complex, because that's what we do as academicians. This is a depiction of the peripheral tissues and the hypothalamus. So this is a picture of if I cut my head right here in half, okay, and I went right through my third ventricle and I'm looking down on my hypothalamus. Right here is the hypothalamus that I'm looking down upon. You can see structurally there's this thing called the arc. That's called the arcuate nucleus. And we have our hypothalamus here. That's going to be the major player. So this tiny little center of your brain is telling you when and when not to eat, potentially. But what we see is that we have all kinds of things that feed into that, and those are all of our peripheral tissues, stomach, adipose tissue, releasing various factors. And that goes into this strange little area here, which is the arcuate nucleus, and it signals the MPY, or agouti-related peptide neuronal bed, or nucleus. And that little nucleus of neurons is the orexogens. Okay, that's the orexogenic area that says, please eat. So I have a little O there. And then we have this concomitant nucleus that's right there at the arcuus that has cocaine amphetamine-related transcript release and pro-opioid melanocortin release. That's the anorexogenic center. So we have these two little nuclei that are feeding back. And our peripheral tissues are going to be releasing these hormones that are going to influence that. You can see over here, we won't pay much attention to it, as some of these things actually go to the vagus nerve. And they go to that vagus nerve and go up to the nucleus tractus solitarius and also have some influence, but this area here is our major pathway that's being influenced by leptin, PYY, GLP-1, insulin, etc. And of course it goes back into the hypothalamus. 4 different nuclei, extremely complex. How do we know all this stuff? It's not exactly like we're doing this in dogs. We know this from a lot of rodent studies, rats, mice, and a little bit of what we know in the human being, okay? So does it all translate? We think it does. And we know that some of these hormones are released, and we know that there are some physiologic consequences, and we'll talk a little bit about those. So these are, I say, the most important ones in general. And the reason I say that is because these are potential pharmacologic targets, okay? So we have GI-released peptides like cholecystokinin, insulin, okay? Those two are wonderful because you can actually suppress appetite. Unfortunately, CCK is pretty short-lived. Insulin's a little longer-lived, but imagine a pharmacologic target. I do not want to antagonize or create an agonist that's an insulin agonist because I have a lot of physiologic consequences on glucose metabolism, not just eating behavior. So it's not a great pharmacologic target. Same thing for CCK. If I were to go to CCK and say, hey, let's mess with this hormone, my pancreas is going to suffer some consequences and not be able to release the appropriate things for digestion. So their global consequences make them pretty bad targets from a pharmacologic perspective. Interestingly, PYY and GLP-1 are anorexogens, and so those are things that are released after you have a nice big fatty French meal, you know, a little red wine and lots of butter and all these cool things. Now I get a PYY release and I'm feeling pretty good about not having to eat for about 6 days, right? So all is good. And the nice thing about those guys is that they really don't have a whole lot of other functions in the body. GLP-1 does have some insulin sensitizing effects, but if I can release those, I can sort of dampen my eating response at the level of the hypothalamus. Ghrelin's interesting because, as we just pointed out, it's the only orexogen. Okay, so ghrelin's getting a tremendous amount of attention for a whole variety of reasons, but primarily there are ghrelin analogs out there to help the cachectic patient, to get them to try and eat more. And so those are all in clinical trials right now. Actually, there will be one probably on the market next year for dogs, which will be a saving grace. Is that we have those older dogs, maybe they got cancer cachexia, renal cachexia, etc. Capromorelin will likely be released once the FDA approves it to help potentiate eating in those dogs that are having a hard time. So if we have drugs, we can see we're starting to have the pharmacologic capability to really affect some of these eating behaviors, and that's going to be a pretty wonderful thing. We're going to talk a little bit about leptin, because it's the adipose-derived, only one that's really adipose-derived that can truly influence your eating behavior. And we'll talk about leptin because it was probably considered, I'd say, to be the holy grail. Okay? When they discovered it in 1994, they said, oh, we have the solution. We're going to make cool inhibitors or cool agonists that are going to stop people from eating as much. But what's actually more interesting is sort of the backstory to leptin. So back in the 50s, Jackson Laboratory actually had a fat mouse, like the one you see in that picture. And they said, how do you get an 80-gram mouse that just won't stop eating? Okay? And they didn't know. We didn't have molecular biology. We didn't have all these cool tools, PCRs, et cetera, going on. And so they basically kept that mouse around, and they had that strain. And they said, there's something interesting about this mouse. Well, lo and behold, another strain of mouse from a different line came along, and they said, we got 2 fat mice from 2 completely different strains. Must be the same mutation. But then they did something that, of course, you would think to do in any kind of situation like that, is they actually fused the bloodstreams between the 2 mice. Okay? Got to do it. Got to try something. And they found out that one was OBOB, which is a leptin mutation. The other one was the receptor mutation. And the cool thing is when you fuse the bloodstreams, the mice who had the screwed up receptor never responded. But if you had screwed up leptin, you could get the normal leptin from the mouse who had the screwed up receptor, and it stopped the one mouse, when they fused together, it stopped it from eating entirely. They just stopped eating. And they're like, okay, we know we have a receptor hormone thing. So this is 1970s. We have a receptor and a hormone that we know controls appetite. That's when the research really began, because they knew that you could control appetite based on receptor hormone type of algorithm. Now, leptin was found to be released from a whole bunch of other tissues. It is sort of in the cytokine family, a TGF, I believe, beta type of a molecule. And we know in people who have OB mutations that they actually have appetite suppression problems. So they will overeat. And this was going to be the next big thing. So you're going to be able to make leptin as a peptide. You inject it into people, or you give them some sort of oral analog. And then they would, hopefully stop eating long term. Problem with the peptides is occasionally you get immunologic reactions to foreign peptides when they're injected into you. So that didn't work out very well. And then they found out that the analogs that they were using to try and suppress appetite really didn't work that well long term. Because the hypothalamus, let's face it, evolution kind of protects us. If you stop eating, your body finally says, okay, you got to eat. If you're not eating, you're not going to live. So the hypothalamus downregulates the receptors and says, this must be a fluke. And so leptin became known as somewhat of we'll call it a long-term signal to sort of slightly suppress appetite during times of gluttony. But eventually your body overrides that signal and says, I still like to eat. Okay? So it really became the unholy grail. So people started looking for other things that might be as good or as interesting. And so we'll talk a little bit about some of these other things in a few minutes from a pharmacologic perspective. But as far as leptin's concerned, we had to, of course, look at it in the dog and say, okay, is the dog responding like the other species, like rodents and humans? And what we know from Ishioka's work in the early 2000s is that leptin does go up based on body fat. So they did dual X-ray absorptiometry on a bunch of dogs, 10 of them, and said, okay, here's the body fat percentage. What's the leptin concentration in the bloodstream? Lo and behold, dogs are very similar to other species, which is great. They looked at a bigger cohort of dogs, and they looked at the body condition scores, and they showed that leptin increases based on body condition score. But what I'll show you is that everything's pretty tight down here as far as numbers. Once you start getting really fat, your numbers and the spread is a lot bigger. So there is some genetic component to it. There may be a breed component. There's a whole lot of different components to it, potentially. But we definitely know it goes up. So that comes to our little Labrador study. We decided to bank a whole bunch of Labradors based on a genetic study that was happening. And we had all this serum laying around in the freezer. And I said to myself, well, let's just see if Labradors are going to sort of fit the mold. And what we did is we looked at all these dogs that were deemed normal through CBC, UA, chemistry, comprehensive physical examination. They had radiographs to look for osteoarthritis, all the good things in life that Labradors have. And then we basically quantified them on a 1 to 9 body condition score, but then we kind of lumped them back into 4s and 5s as lean dogs. So you'll look at graphs here that say lean, overweight, and obese. The overweight dogs were 6s and 7s, and the obese ones were roughly 8s and 9s. And you can see here, Labradors and leptin, just like all the other breeds in general, is that they started off pretty low, around 5 nanograms per mil, and then it actually goes up as you're overweight to obese. But you can see, once again, there's a pretty big spread once you're overweight to obese as to your leptin status in general. And that may have something to do with the overall inflammation of obesity. But at least we stuck within one breed, and we see that this is all very similar to when you look at various breeds. So your leptin secretion can be a little bit different depending on your overall chemistry, physiology, and probably what you're eating as well. So let's go back a little bit to, can we alter these pathways, okay? So we know leptin is not the best target. Nobody really looks at that anymore as a potential pharmacologic target. And just to break it down once again, because saying things 3 times makes it stick sometimes, is that we have anorexogens and orexigenic pathways. These are MPY neurons, these are POMC, leptin, insulin, PYY, and GLP-1 all will affect the POMCs, stimulating them, basically causing an anorexigenic behavior, and they'll actually dampen the MPY pathway. Ghrelin's the only one that will actually create an orexigenic behavior, and it dampens this pathway and augments this pathway for orexigenic behavior. So can we alter it? Does anybody know of any drugs on the market in the human world that actually are being used this way? Slentrol, oh yeah. Okay, that's my second slide. So we'll talk about first slide in the human market right now is something called Victoza, okay? So anybody out there, you all look pretty lean, unlike myself. So most of the people here are lean, so you've not been introduced to the idea of Victoza as a pre-diabetic drug. So if you are my uncle, for example, we went to his house and he had been to the doctor and he had been told that he was sort of pre-diabetic. Blood glucose was getting a little high after an oral glucose tolerance test. So they said, you know what, you're a little bit overweight. We're going to put you on Victoza, which is an insulin sensitizer. That is GLP-1. So they actually have an analog GLP-1 peptide. It's on a little dosing thing. You give yourself a little injection. You can ratchet it up for a better effect, ratchet it down for less of an effect. They find an optimal dose. It helps insulin sensitize you so that you actually have a lower blood glucose after eating. What I actually noticed about my uncle, and I asked my aunt, and I said, he's a 4 to 5 slicer when we get a pie. He only ate 2 slices. I was like, is he dying? And, you know? And she's like, oh no, he's on this new thing. He doesn't want anybody to know. He's on this stuff called Victoza. And so she showed me the little thing, and I said, oh, it's a GLP-1 analog. And you know what? He was eating less. It was amazing. He did lose a few pounds, but unfortunately GLP-1 side effect is it makes you a little cranky. Okay? You get a little malaise, you don't feel quite yourself. Hence, it's not really designed to be a true appetite suppressant, though it does. And then once again, just like our problem with leptin, is eventually your brain says, well, this really isn't probably the real response. I really should ratchet up. That's why it's on a little dosing syringe that you can give yourself a little bit more depending on your sensitivity. So we talk about that in the world of humans. We had Slentrol. I don't know if we have it anymore. I think it's been taken off the market because it wasn't really selling very well. But what Slentrol does, as it goes into my really bad rendition of an enterocyte, Slentrol goes in and inhibits the microsomal transferase. Microsomal transferase is supposed to be making these little chylomicrons right here. And those microns are supposed to be going into your lymphatics and you absorb your fat. Well, what happens is when you inhibit this microsomal transferase, you start to build up fatty acids inside that cell, and those little fatty acids just sit around. Well, what they didn't teach you in vet school was that those fatty acids actually can go to the nucleus via fatty acid binding proteins and have signaling effects. And what happens is that all the beagles that were looked at Pfizer back in the day when they were studying this, is that they actually had an increase in PYY in their serum. That is the effect of Slentrol. Slentrol actually caused a 2 to 4-fold rise in PYY, and that's why when I used to try it occasionally on a dog, they just stop eating. And that freaks people out when your dog actually looks at the full bowl and walks away and doesn't want to eat. So its popularity wasn't great because, once again, you had to titrate the dose to an effective dose, and then once you had an effective dose, you had to kind of mess with it. I think that was part of the reason that we have no really good drugs, is because we have to do all this strange titration. It's not 1 pill a day, have a great time. It's not like a cyclooxygenase or LOX inhibitor. Yeah, give this. Guess what? Your dog is going to feel better. I don't care what dog it is. All right? So we're changing gears a little bit to this whole idea of fat as an endocrine organ. What you can see here is all the various cool things that are released from a fat cell. And you can see there's things like adiponectin and leptin in the red there. But then there's a whole variety of other things that we know are being released from fat cells, and we don't know a lot about a lot of these things. But we know cytokines like TNF-alpha, IL-6 may also be part of that chronic inflammatory response. And here is a picture of a we'll call it a crown-like structure. That's what they like to call them in fat. That's from a mouse where you can see that there is a adipocyte that is being rimmed by inflammatory cells. That is the evil guy. That's the chronic inflammatory response that's occurring. Strange part is no one has yet to really look at that and say, oh look, dogs have more of these structures when they're fat. Cats have more of these structures when they're fat. There's very little research out there showing this. What I'll tell you is we've been doing some work in dairy cows. I've yet to find a crown-like structure in a fat dairy cow. So there may be species differences that we're going to have to talk about at some point. So adiponectin multimerizes into a large complex. How many adiponectin molecules attach to one another in this huge complex? I'm sure you're all going to get this right. Anybody want to phone a friend? All right, looks like 12 is winning. What I'll tell you guys is that 18 is the way to go. Okay? 18 monomers form the true high molecular weight adiponectin that is the insulin sensitizer. It's now going up. Everybody, go, go, go. Come on. We'll win, we'll win, we'll win. You're all geniuses. So 18 is the way to go on that one, and this is sort of a rendition of that, showing hexamer up here, which is middle molecular weight versus a high molecular weight. Adiponectin is great because it's an insulin sensitizing hormone. It acts almost like the TZD drugs, which I can't even pronounce, the thiazolidinediones. The TZDs, like rosiglitazone, which is used in people. Unfortunately, it causes heart attacks. Well, hey, who knew that was going to happen? But we have these kinds of things that actually some people are starting to use in dogs as a insulin stimulating type of effect. Now the cool part about adiponectin was that in around 2008, 9, 10, I was doing some research and I sat back and I said, why the hell doesn't adiponectin ever change in dogs? And I never really wanted to release that data. And then somebody said, oh, come talk about it. And I came and I went to this conference and I started saying, you know what? We don't see adiponectin decreases in fat dogs like people. And adiponectin is an insulin sensitizer. If you're fat, it goes down. Therefore, you're not as insulin sensitive. And I said, well, I must be like on drugs. I'm not doing my assays correctly. I can't be that dogs are that different. After I gave that lecture, this guy Verkes came up and he goes, oh, dude, I'm so glad you did that because we're showing the exact same thing. And he had just submitted some papers, and he basically wrote 3 papers revolving around the fact that adiponectin, as an insulin sensitizer, is basically always high in dogs. When you look at it across species, and this was one of his papers where he showed really cool things like insulin, GLP-1 concentration is not changing, but leptin goes up, insulin goes up as you get fatter and fatter. But here, adiponectin doesn't change one iota. And the adiponectin concentrations are probably 2 to 4 times higher than many other species in dogs. So dogs are adiponectin. God just loves dogs. Let's just put it that way. He gives them a hormone in their bloodstream all the time that actually makes them a little more insulin sensitive. Okay? So now we start to maybe, and I'm just going to put this out there, we start to maybe start understanding why dogs don't get type 2 diabetes as much, and their insulin resistance. It takes a really fat dog to get really insulin resistant. Okay? This is some of the work we did, basically showing that across the board, before and after weight loss, that the adiponectin concentrations did not change via Western blot analysis, and this was the average change across the pre and post weight loss period over a 6-month period of time, showing absolutely no difference in our overall adiponectin. So let's go into 2015, looking at various populations. We'll look at beagles. There's a paper just released looking at just beagles and their adiponectin, and you can see during weight loss in 18 beagles that the overall adiponectin concentrations do not change one iota over a 6-month period of time. We go and we look at our cohort of Labradors, 93 Labradors, and we can show that basically adiponectin from a statistical point of view does not change either. So we pretty much know that dogs are special regarding adiponectin. Talk a little bit about C-reactive protein because that's what's in the literature in the human side. We've looked at C-reactive protein a lot in dogs, and I'm only going to say a couple of things about this from the perspective of it is a marker of chronic inflammation. It's used in the human literature as a risk factor for diabetes. It's used as a risk factor for cardiovascular disease. And there's really good evidence to say if you have a chronically high C-reactive protein, you are at higher risk. If you're obese in humans, you tend to have a high C-reactive protein. The problem is that in our dogs, it's a bit equivocal, because there are a lot of studies out there that have shown if I rapidly induce weight gain in a beagle, C-reactive protein doesn't change. If I induce weight loss, C-reactive protein doesn't really change that much. So this whole idea, once again, like adiponectin being somewhat special, this whole idea that C-reactive protein rises and falls based on obesity is not particularly well established in dogs. And what I'll say is that cats are always different. Cats don't even make the dang thing. All right? Dogs make plenty of C-reactive protein to all kinds of stimuli. An infection causes it to go through the roof. Pancreatitis causes it to smolder. Lymphoma causes it to smolder. Obesity just doesn't seem to have that same smoldering effect like it does in rodents and humans. And that may be because the inflammation just isn't quite as severe as in some other species. And then cats, well, they're cats. So what is the average C-reactive protein concentration in your average healthy dog? And I will say that I did do a typo. It's all based on milliliters, not deciliters. But anyway. Is it 1 to 3? Is it 5 to 20, 50 to 20 to 50, or 50 to 200? So I just wanted to do this question to point out that if I am a dog who has an infectious disease, my C-reactive protein is going to be somewhere around 200, 300, 400 maybe. If I have pancreatitis, it's going to be around 50 to 80. If I have obesity, in the human world, it smolders in this range, maybe 5 to 20. Normal dogs are somewhere in this 1 to 3 or 1 to 5 range. Okay? So 1 to 5 is typical, or 1 to 3. And what I'll tell you is that Labradors, when they were looked at for the C-reactive response in the lean, overweight, and obese, there was absolutely no difference. So yet another piece of evidence suggesting that C-reactive protein just does not really rise in dogs like it does in people. So our next question is, we're going to move on to cytokines. So we know that this inflammatory response really doesn't happen that well in dogs, or at least we don't think it does because of the C-reactive protein response. What's happening to the cytokines that are these related to the obesity phenomenon, IL-6, TNF-alpha? So how many studies have been done now on cytokines in dogs? Across the board, 10, 5. Who's going to win? And this will actually include our study, of course. So basically, 2 have been done. Okay? So really, the reason that only 2 have been done, there's actually, we'll say there's kind of a third, where they actually tried to look at TNF-alpha in obese and lean dogs. And that study, the assay was not particularly robust, and they fell below the lower detection of the limit. And they said, well, based on the assay, we had a few obese dogs that made it above the detectable limit. So we think there's some obesity going on, or there's some inflammation, there's some cytokine release due to obesity. And that was the only thing for about 6 or 7 years. So people said, yeah, it's happening. And what I'll say is that just recently, a paper came out looking at beagles over a 6-month weight loss periods. They were body condition scores of 8. They went down to a 5, a nice lean phenotype. And of course, they serially took blood samples and looked for cytokines. Now, I'm going to say that we also just did the study, which we ended up with 91 Labradors in this cohort. And we used a slightly different cohort of Labradors than we did for the adiponectin leptin work that we had just done. And of course, we have our same criteria, basically lean, overweight, and obese. So you'll see some data based on that. But the big difference between our 2 studies was that one used what was called the multiplex kit, which is basically fluorescently antibody-coated beads that go through this little chamber, and it tells you the fluorescence based on whether the cytokine is binding to the bead. And we used something which was called an electroaffinity ELISA, which basically sort of makes sure that the charged proteins stick around, and if they stick around and bind to the antibody, then you get a positive fluorescent signal based on this mesoscale scientific hit. Really interesting stuff that you're going to take back to your clinical practice and use, I know. But this is some of the nuances when you read data and you read research to say, well, why is this guy showing this and this guy showing that? Well, the reality is I have two different assays. And what we think is that the assay we use may have a slightly better sensitivity than the one that was used in the Beagle study. But they got to do cool things in this kit that we didn't get to do. They got to look at about 20 different cytokines. And I'm only going to talk about the 4 that really crossed over as far as inflammatory cytokines are concerned. That was interleukin-6, TNF-alpha, IL-8, and MCP-1, all considered to be inflammatory cytokines in general. We also looked at interleukin-2, which is a T-cell stimulus, sort of looking at immune status. And then there's also interleukin-10, which is cool because interleukin-10 is thought to be an anti-inflammatory cytokine. Okay? So we looked at the same things. And I'll show you here in the Labrador stuff that we did is that if we look at it from a statistical point of view, you can see that if you're lean versus overweight or obese, that the IL-6 concentrations do rise, okay? And that is considered to be the major inflammatory cytokine that is supposed to be released from fat tissue along with TNF-alpha. So we did see that rise that I guess we expected would be seen in the overweight dogs. TNF-alpha, interestingly, we saw no changes really in TNF-alpha. So here's TNF-alpha right here, and we have no difference in our TNF-alpha concentrations. We actually looked at interleukin-8, and from a statistical point of view, there were no differences across lean, obese, overweight in that category. And then MCP-1, which is a global marker of inflammation, sort of saying, hey, are my macrophages active? We did see a rise in MCP-1, which has also been documented in dogs. So what I guess we can sort of say based on this data is there is a mild chronic inflammation that is probably associated with your body condition score. Okay? If we look at the beagles, interestingly, they couldn't do IL-6 because most of their samples did not reach a detectable level based on their assay. So we don't have anything to compare it to the IL-6. They actually showed that there is a mild decrease overall in interleukin-8 over time, which is almost anti-inflammatory. So you'd expect that. These beagles were losing weight. This chronic inflammatory marker is going down over time by 6 months. What you can see here is this bizarre gray line, and that basically says this is how many samples were below the detectable limit. Look how many were below the detectable limit. So they're basically saying is that there's a global decrease, we think, and therefore this may be significant. TNF-alpha, just like us, they showed no difference in TNF-alpha secretion at all, which is right here over time. And then here, MCP-1, they actually showed over time and weight loss, the MCP-1 concentrations do decrease from a statistical standpoint. Okay? So yes, we think there's a similar inflammation going on in these beagles potentially. They just couldn't get their IL-6 to be detectable in their assay. So we're kind of corresponding quite well. We go on to look at interleukin-2, which is the T-cell stimulus. You can see here that in the beagles, there was a decrease in interleukin-2, so this whole revving up of your T cells may be dampened a little bit, while we showed basically a very, very mild decrease as well. And so in the end, we don't think there's a huge response in the T cells, but we weren't really expecting that either. Probably the coolest part of the entire thing was that in our Labradors, and they couldn't measure this in the beagles because of the lower detection limits that they had, but in our Labradors we actually showed that there was an increase in IL-10 over time here. Lean, overweight, and obese, you can see the IL-10 actually starts to go up. These were dogs that are all grouped into one category because they were in the lower detectable limit. But you can see there's far less in the obese than in the lean. And what we see is that this effect that's happening is an obesity effect of anti-inflammation. Absolutely bizarre. We don't know why it's happening, but we know that it is happening. But what's kind of cool is that as IL-10 tends to go up, guess who stays up as a fat-related hormone? Adiponectin. So for whatever reason, this IL-10 is going up over time, may be actually related to why adiponectin kind of stays high in our obese dogs. And we don't understand exactly why this is happening. But once again, this is all just new information, and I'm sure somebody's going to either debunk it or continue to prove it right. So in summary, our adipokines may be different in dogs. We know that adiponectin probably has a slightly different role, or let's say not a role, but actually stays heightened and elevated in the obese dog compared to to people, where as you get heavier, your adiponectin decreases. Our inflammatory cytokines definitely may be up, but the jury's going to be out for a while. And there's a strange thing happening with this IL-10 response that we don't really understand. Of course, we need a lot more population-type studies. We need to look at slow versus quick weight loss, quick weight gain. And then, of course, our correlation between CRP and cytokines would be very interesting to look at, and we haven't done that. And of course, we always bring in this whole thing with osteoarthritis, which is really the main theme of this entire conference. What happens to the dog who's fat and has osteoarthritis? Are their cytokines even higher, which we would expect they would be, versus the typical obese dog? And if you have OA, do those cytokines actually relate to your insulin sensitivity and things like that? So lots of questions to be answered.
All right. Thank you very much. Thanks, Joe. Great lecture. Thank you very much. So I learned that it's not my fault. It's not the eating part. It's just the endocrine system that does this to me. So I'm totally okay. We have 4.5 minutes for questions. Any questions for Joe? Yes, I see a question in the back there. If a runner can go there, perfect.
Dr. Waxlak, thank you for a wonderful review on this topic. Congratulations. My question is regarding the detection of inflammatory markers in the acute obesity model versus chronic obesity model. Has anyone looked at C-reactive protein in acutely induced obesity versus long-term obesity? And were your Labradors that didn't change CRP concentration at obese state chronically obese or acutely obese? Because I'm trying to figure out, does it have to be long-term obesity to really see CRP increase? Thank you.
Yeah, I think that's the crux of it, is that most of those acutely induced models are the ones where we don't see the phenomenal rises, right? I think the European groups have kind of shown that. And I think this whole idea of chronic obesity may be really the sort of the kingpin here. Am I obese for a long period of time? Therefore, yes, I'll have a higher CRP, and I may have a depressed adiponectin. I think you guys have very well shown that our body condition scoring system doesn't do us justice too, right? So once you get to 9, there's really a 9 plus and a 9 plus plus, okay, or a 5 plus, whatever you want to call it, because 40% obesity is a 9 on the 1 to 9 system, right? But there's the 50 and the 60% obese, the 50%, 60% fat. Those are the ones that may actually be the ones that actually have the high CRPs and the low adiponectins. And I think Alex German has really shown that if you have other markers in your serum, high triglycerides, what else was it? I think a systemically high blood pressure, those are the ones that tend to have some of the more metabolic problems. So these markers are great, but I think he was kind of going back to say, listen, if you have a high triglyceride and you have systemic hypertension, you better worry a little bit more about the inflammation of obesity and things of that nature. So yeah, I think this acute versus chronic is a great thing. And my Labradors, I'll just tell you, they were fat. Nobody could tell me like, oh yeah, he got fat at 6. And the average age in our population was around, I think around 7 to 8. So we had sort of this spectrum between 2 and I think 14 years of age in those Labradors. And when we tried to do some regression stuff on age, didn't pan out. So we just kind of left it as, okay, yes, they go up, and this is a global population of Labradors. Age couldn't really play a factor, but we didn't have a whole lot of young dogs. We had a lot more 6 to 12-year-olds in general. So.
Great. Thank you very much. Any other questions? If not, big hand of applause for Joe. Excellent. Well done. Well done. Well done.